Hello, my name is Francine Raynone, and I'm the Medical Director of the Palliative Care Service at Lourdes Hospital. This morning I'm supposed to tell you about our service and also a very little bit about pain management. I think we should start by taking a broader view, a wider view, and reminding ourselves of what we're all about as physicians. If we truly care about our patients, then we'll see that the relief of suffering and the cure of disease are twin obligations. And if we don't understand the nature of suffering, and if we don't understand that medical interventions may actually become a source of suffering itself, then we will not do the best job possible for our patients. People have many confusions about palliative medicine. I would like to explain some of the differences. Traditional medicine is focused on cure of disease, so it is a disease-based, cure-based process. In palliative medicine, we are not focusing so much on disease as on the functional status of the patient and care with or without cure. Traditionally, medicine is focused on a diagnosis and treatment that uses an organ-based system, an organ system-based model, and we are doing simultaneous management of many diseases and conditions and focusing more on the big picture. In contrast to traditional medicine, in which physicians often work alone, palliative medicine is intrinsically a team service. What we do here at Lourdes is we have an inpatient consult service that is by physician referral. We also have an outpatient clinic, either by referral or for hospital follow-up. And the team includes a physician, a nurse practitioner, a nurse coordinator, a chaplain, a massage therapist, a social worker, and a medical office assistant. Lots of people are confused about the difference between palliative medicine and hospice. Hospice is reserved for people when they no longer desire curative treatments. Palliative medicine is provided along with curative treatment if that is desired by the patient. That means there is no time restriction on when you can actually refer to palliative medicine, whereas for hospice, there's a requirement that death is expected in 6 months. Those are the main differences. Otherwise, we have the same hospice philosophy of evidence-based symptom management and using a multidisciplinary team to respect patient and family wishes. Until now, people have generally referred to palliative medicine too late. If you look at this, which is the Ascension Health model of palliative medicine, you can see that at the very beginning of diagnosis of life-threatening condition or debilitating illness, the need for palliative medicine is rather small. But as treatment progresses, you get a differing amount of need for palliative medicine, and then as we get closer to death, really the treatment is all palliation. We are treating patients whether or not their disease progresses to death, and the sooner we get people, the better off those patients are. For instance, there was a study in New England Journal of Medicine showing that people with stage 3 and 4 lung cancer who were referred to palliative medicine actually lived about 3 months longer than those who were not referred. So I can give you a long list of indications for referral, but basically the underlying principle is if you have severe advanced disease, that's a reason to refer to me. Metastatic recurrent cancer, neuromusculoskeletal diseases such as MS, oxygen-dependent COPD, end-stage renal disease, people who've had an anoxic event and are unresponsive for more than 24 hours, multisystem organ failure, dementia, and advanced cardiac disease. We're currently in a project with cardiology to see more and more of people with heart failure, especially systolic failure with an ejection fraction less than 25%. Other indications are when difficult decisions or difficult care management is indicated. For example, the decision to have a tracheostomy or a PEG, someone who keeps visiting the emergency department, someone who is readmitted to the hospital for the same diagnosis in 30 days. That's obviously a big topic lately. And so there are multiple indications, and again, the overarching principle is if someone has severe advanced disease, they will probably benefit from our service. How will you benefit? Well, for one thing, you will save time. And what I mean by that is that we have a team that systematically goes through symptoms and concerns with the patients every time we see them. We recheck and recheck and move forward the conversation about values and goals of care and treatment options in a way that busy practitioners who have to see multiple patients simply do not have the time to do. We're also here for support. We support you, and we also support patients and their families. And I don't have to tell you that facilitating a plan of care is difficult and requires a team effort. We also provide expert symptom management, and with a reduction in symptom burden, we generally lead to improved patient and family satisfaction. So I'm asking you to let us know how we can help, and we are very happy to help you. I do also want to mention that we will do consults in the emergency department if that is indicated. At this point, I'm going to turn to pain management and the policy at Lourdes. The policy here is the same as everywhere else, that you need to assess with a 0 to 10 rating scale or words. And in general, elderly people don't really have a sense of what 0 to 10 means. They're more comfortable saying their pain is either mild or moderate or severe. The translations are that 1 to 3 correlates with mild, 4 to 6 correlates with moderate pain. And if it's moderate pain, it does require intervention at that time. Severe pain, which is 7 to 10, according to our policy, requires a licensed independent practitioner's intervention. We've all been told that the gold standard of adequate control is patient reports. I want to add that we're also very well aware, all of us, of the limitations of this kind of assessment of pain. It does not take into account a multitude of factors, including what the patient themselves would say is an acceptable level of pain. If they say 6 is acceptable and you get their pain to 6, then you've done a good job. I often have to tell people what 0 to 10 means. I've noticed a kind of grade inflation that lots of people are rating their 10 9. So I will often say on this scale of 0 to 10, 10 means you are going to die. And then I'll give them a reference for 5. And then I ask them to rate their pain. And if you can give a little guidance, you will find that the pain scales are more accurate and that they are more useful to both you and to your patient. I'm giving a little glimpse into examples of treatments. For mild pain, sometimes reassurance is enough. Often, non-pharmacologic therapies such as distraction and stress reduction are perfectly good ways to manage mild pain. And of course, you may want to offer medication just as a way of educating people about pain medicine. And of course, you would start with either acetaminophen or a nonsteroidal. For moderate pain, we begin to introduce opioids, usually in combinations with adjuvant medications. One thing I just ask you please to do is the math. We have developed an equianalgesic chart. There are also equianalgesic charts and calculators that are available online as applications. I frequently see people giving 1 milligram of IV hydromorphone, no matter who the patient is. Please remember, if you do the math, a milligram of IV hydromorphone is 20 milligrams of morphine by mouth. This is not a good choice for someone who is not already on opioids. It's not a good choice for the elderly as a first guess. I have given as little as 0.2 milligrams of hydromorphone in the very old. Before you go increasing the dose because you go back to reassess and the patient says, oh, that didn't do anything, I'm still in pain, yada, 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 it's important to check whether they actually have gotten their medication, check for side effects. Are they not taking their opioids because they are nauseated or it makes them feel loopy? Of course, check a bowel regimen and whether they're on a bowel regimen. And then also assess whether these medications have helped them function better. If they're saying it's not working, but now they're getting out of bed and doing laundry, then it probably is working. And it's important to let them know that, as well as discussing whether to increase the dose. Also, always remember that comorbidities have an effect on pain, and unless the patient is being managed well in a holistic manner, their pain will be unrelieved. Severe pain is considered a medical emergency. On the inpatient side, we're going to very rapidly titrate medications. We don't pay attention to the milligrams, but to the degree of relief from pain. On the other hand, we pay attention to side effects of increasing doses. And if you have any questions at all, I'm very happy to be called. Again, if you're going to start pain meds, I urge you and I request that you do the math. If someone is opioid naive, which means that they haven't taken a dose, even if it's only been 2 or 3 weeks, you probably would start with a low-dose, short-acting medication. If they've been on opioids for more than 2 weeks, then you can titrate based on the pain level and the degree of response. On the inpatient side, continuous infusions of opioids are very useful, and it is a rapid way to get pain under control. Our team will check on people at least twice a day to see whether the dose is correct. Please do not start pain meds by slapping a fentanyl patch on someone. You will simply be guessing at how much they need. It's going to take 12 to 17 hours to kick in, and then is going to remain in the system after you take it off if you've made a mistake. I have included a couple of slides on titrating oral opioids. If mild pain is unrelieved and has required opioids, you should increase the 24-hour dose by 10 to 25%. Moderate pain is 25 to 50%, and unrelieved severe pain is 50 to 100%, which means someone with metastatic cancer who is getting 80 milligrams of oxycodone continuous release per day should be increased either to 120 or 160 milligrams of sustained release oxycodone. Instead of waiting for your patients to be constipated and then prescribing medication, the hand that writes the opioid prescription writes the bowel regimen. Also, as a note, our pain management policy here has restricted Demerol to drug or blood product-induced rigors, post-anesthetic shivering, and a true allergy to all other pain medications, which I personally have never seen. So basically, Demerol is probably not available to you. Summing up, when we're treating pain, we're treating a multi-dimensional experience that requires a multidisciplinary approach. Pain is not just physical, but occurs in the bio, psycho, social, spiritual continuum of human experience. Physical causes of pain can be relieved in probably 95% of cases with available medications, but you cannot relieve physical pain without treating the whole person. I thank you very much